box to drop questions in, as well as the Q&A box. So without further ado, I'll turn it over to Dr. Benji Matthews.
Thank you, Kevin. Appreciate it. Welcome everyone to SHM's Point of Care Ultrasound series. We are your moderators. For those of you I've not met, I am a hospitalist in Minneapolis-St. Paul, work at Health Partners and teach students and residents through the University of Minnesota. Been a part of ultrasound training with our hospitalist group, about 200 hospitalists in our department. I serve on the ultrasound steering committee along with Dr. Johnson. And I'm co-chairing this SIG with Gordy Johnson. Gordy's picture looks great there, but you know, Gordy's so good at scanning ultrasound. Here he is scanning himself without a transducer. So Gordy, do you want to introduce yourself?
I'm actually giving a thumbs down to Benji Matthews there, I think. Yeah, Gordon Johnson, Portland, Oregon. I'm the POCUS Director of Legacy Health System here in Portland, Oregon, and co-hosting. Thanks, Benji, and welcome everyone.
Perfect. Before we introduce our speakers and session, wanted to just share the opportunities through the special interest group. As a rotating series, as you can see, that'll be advertised via SHM's HMX platform, social media on Twitter with the hashtag POCUS Chat. There's didactics, journal club, case-based discussion. Areas you can really get involved in are the case-based discussion pieces. The first one is in August. If you have a case, reach out to the SIGs at shm.org with the subject line POCUS SIG. The staff and co-chairs will then further provide direction on how to submit a case, and we'll select a handful to share with the national audience. Our next session after today is on July 21st with a POCUS Journal Club. The rest of the series is noted with a rotation, as you can tell there, between a webinar, a journal club, and case-based discussion. So additionally, there'll be updates on HMX on other activities, other journal club ideas, or neat novel ideas as well. And so follow us along there. So as a summary, here's how to get involved. Emails, again, sigs@shm.org with the subject POCUS SIG. Follow us on social media. Here's our handles, and use the hashtag POCUS Chat. And finally, join the SHM member platform and continue the conversation via HMX Exchange. All right, that was rapid fire. It is next our honor to have these two national experts in point of care ultrasound and procedures. From the University of North Carolina, Dr. Ria Denzel is an associate professor of medicine and pediatrics. She is the medical director of point of care ultrasound education, and her major focus is on simulation training for diagnostic and procedural ultrasound. So we look forward to having her share about her program and the 5-year experience, and a recent publication that is well received as well. Dr. Ricardo Franco is an academic hospitalist and associate program director of the internal medicine residency program in Naples, Florida, there in the healthcare system there. He has started not one, but 2 procedure services over the course of his marked career at Cook County in Chicago and the Medical College of Wisconsin. He has been on lead publications, a great mentor for many of us on procedures with ultrasound through the Journal of Hospital Medicine. So please join me in welcoming Drs. Dancel and Franco. We'll hand it off next to Dr. Dancel for a brief presentation.
Hello, everyone. All right, so I'm going to share my screen. Thank you for coming. I see so many faces and friends out there. Thanks so much. Okay, I'm getting my PowerPoint together. This is going to be brief. We mean for this to be an interactive webinar. If you have a burning question, I am okay with being interrupted. I like conversation, so if this is a conversation, that would be great. So again, I'm Ria Denzel. I'm an associate professor of medicine and pediatrics. I'm the director of our medicine procedure service here at the University of North Carolina. And actually know Ricardo through Dr. Neelam Soni, who is a mentor, is one of my mentors, and is a mentor to many of us here. And I said, hey, I've been tasked to start a procedure service. This was in 2014. I just cold emailed him in Vegas when we had SHM Vegas, and he said, yeah, I'll be happy to meet. And he introduced me to Dr. Franco, who was at that time at Cook County, his first of 2 procedure services that he started. And so we recently published our 5-year experience at UNC. And so I'm just going to go over a little bit of how we started our procedure service. We get questions like this all the time, which is the inspiration behind this webinar, of folks that are interested in our procedure service and maybe how they can adapt to where they are. So we're just going to go through the nuts and bolts of how we started our service and maybe give you some ideas. In this paper, we also review the outcomes of our bedside procedure service from 2014 to 2015, so our 5-year experience. And then this is really boring, but the CPT codes for billing are things that we get asked for a lot, and I put them in here so that when you review, you have these CPT codes. I'll talk a little bit about charges and receipts, and then sort of the big question of how do you justify having a procedure service? That's the biggest question that we get. So we'll hit on that a little bit. So we started in 2014. We are at that time, tertiary care. Now we're a quaternary care, state-owned academic hospital. We have over 800 licensed beds and continue to grow every single year. We have a new surgical tower going up. We serve patients all over North Carolina and some Virginia, South Carolina as well. Our procedure service is staffed by a hospitalist procedural attending and 1 to 2 resident physicians. We staff 4 to 7 days at a time. I will say being on the procedure service for 7 days at a time is physically challenging. I require that our proceduralists attend 5 weeks per year so that there's little decay in their procedural skills. In general, our new faculty are self-selected. And I think that if you start your own procedure service, you will find that the faculty that are interested are the ones that have just come out of residency because they've done their ICU rotations. They're fairly comfortable with doing procedures still. Now they are used to using ultrasound. And so they're just more comfortable in that space. And so our new faculty typically are self-selected, just graduated. They complete a 1-week orientation and training process with me or my co-director. The medicine procedure service is a required rotation for our learners, and I realize that not all of you are at academic institutions and you may not have learners, but I just wanted to say how we kind of interact with our learners. We have 1 or 2 residents from internal medicine or internal medicine pediatrics at a time. They do 2-week rotations. And they get 1 day off per week. So during that 1 day off, we're alone. The proceduralist is alone to handle all of them by ourselves. We are available 7 days a week, 8 to 5, 52 weeks out of the year. In 2014, when we started, and I think this was key to how we were able to start, is there was very little ask from our C-suite. We already had a hospitalist attending that was staffing Gen Med consults. And we said, well, what if the Gen Med consulting attending did procedures also? And at that point, we had the bandwidth to do that. Our only real overhead was we bought a machine. And so our Sonosite machine was about $50,000, $60,000. And in order to recoup that cost, it was a very low bar of 1 to 2 procedures a day, which is definitely doable, even if you are staffing Gen Med consults. And then it was a case of if you build it, they will come. So we just had people decided that this was this was good teaching, this was good patient care, this was very convenient for the rounding teams to have somebody else do procedures for them. And we were in demand. And so from 2015 to present, the consult service and the procedure service then split off. So there's a consult attending and then there's a proceduralist attending. On the weekends, we kind of collapsed into one attending that covers both the general medicine consults and the procedures. And again, it's just a matter of the procedures getting busier and busier every year. And so now this is new this year, actually starting next month, we will have a 7-day-a-week procedure attending, 7-day-a-week consult attending. So they're completely split now. We perform parasynthesis, thoracentesis, central lines, lumbar punctures, the odd arterial line, the odd IND or arthrocentesis. But for the most part, the bulk of our procedures are paras, thoras, central lines, and lumbar punctures. We are doing more and more lumbar punctures, and we've actually this year started to do intrathecal chemotherapy to help out our oncology colleagues. All the procedures are performed with the attending at the bedside with the resident as the primary operator, unless it's the one day of the weekend when we don't have a resident, and then it's playtime for us proceduralists without the learners. The resident is the primary operator when they're there. And then we sort of step in to complete difficult procedures as necessary. The way that we've set up our referral process is we have a consult order, and then we have a dedicated medicine procedure service pager. So they'll place the consult order in Epic. Our system is an Epic system, and then they'll send us a page and we'll kind of discuss the case. Complex cases, we have interventional radiology that we refer to, neuroradiology for more difficult lumbar punctures, and interventional pulmonology for complex pleural effusions. And if these procedures can't safely be done at the bedside, we'll defer those. And we have really good relationships with those other interventional shared services at our institution. But I think a lot of what we do is to sort of help our primary teams kind of think through what they're hoping to get out of the procedure, help them weigh the risks and the benefits. Being internists ourselves, I think we're better equipped to do that, and then help them interpret the results of the procedures that we do. We have procedure carts stocked on our medicine patient floors, and these carts are stocked with what I have requested as specific kits and equipment for our use. We also purchased a dedicated cart-based portable ultrasound. Like I said, our first ultrasound was a sonocyte. We're sort of a sonocyte institution. And so we have always had a dedicated portable ultrasound machine. I think that's really important if you're going to start your own service, because trying to find a machine when you need it is kind of difficult to do. And so you don't want to have to go looking for a machine when you have your own procedure service. You want to have one dedicated to your own service. And this was supported through our capital budget. We standardized our procedure documentation. So we use dot phrases so that we have consistent billing across the board, consistent CPT codes. And then I also kind of, in the beginning, created our documentation with data in it, embedded in that documentation, so that we could look back 5 years, 10 years, and pull that data out of our EMR. We bill for the procedure itself, and then within 48 hours of having done the procedure, we go back and do a consult visit just to document any immediate complications. In situations where we're asked to do a parasynthesis or a thoracentesis in particular, and we don't see any pathological fluid, or we don't see enough pathologic fluid, we will bill for a diagnostic ultrasound. And for those of you who are academic institutions, we found that it was very important that our residents learn how to do these procedures correctly and safely. They are taught indications, contraindications, the risks and the benefits of the bedside procedures, how to use ultrasound effectively, safety, how to prevent and manage complications, and then how to interpret and follow up imaging and testing when they're done. So just briefly, in our 5-year review, we had performed 3,634 procedures. Almost 75% of them were trainee performed. And so we set out what we wanted to do, which was to make sure that our trainees actually got really good experience. 88.7% of our procedures were ultrasound guided. 100% of, almost 100% of our central lines were ultrasound guided. If you look at it, it says 97.6. That's just because sometimes we forgot to put the picture in our documentation. And so unless you put the image in the documentation at our institution, it didn't count as ultrasound guided. But all of our parasyntheses were ultrasound guided. The ones that we kind of had a toss up were the lumbar puncture. So half of them, almost half of them, were ultrasound guided versus not. So just quickly, you can review these later on when you see when you kind of review the webinar. I just wanted to go through our complication rates, and again, I want to emphasize this is in the hands of trainees for the most part. Almost 75% of these are rate of leakage, which is sort of the highest complication with parasynthesis, was low at 3.7%. Our perforation rate was 0.1%, and our risk of bleeding was 0.6%. And then there was a really large review of almost 70,000 parasynthesis that had a bleeding rate of 0.8%. So lower than what has been published. These are the CPT codes for parasynthesis without and with ultrasound guidance. And you can kind of see the difference in the charges. So average charge without guidance was about $517. With guidance was $860. So it adds up, especially if you're talking about doing thousands of parasyntheses. For thoracentesis, our pneumothorax rate of 3.1% is lower than were reported in a study of both experienced operators, which was 3.9%, and trainees, which was 8.5%. So I think significantly lower than other trainees. Only 25% of our pneumothoraces required intervention, compared to a study of 620 procedures by Gordon et al. And our hemothorax rate was low at 0.5%. This is the CPT code for thoracentesis with ultrasound guidance. I think our biggest procedure as in terms of charges and receipts. Like I said, we're doing more and more lumbar punctures now since we're doing IT chemotherapy. So this was 720 procedures over the past 5 year period. About half and half ultrasound guided and landmark guided. Interestingly, 83% of the cases with a post-dural puncture headache were solely landmark guided, suggesting that maybe ultrasound maybe played a part in having a lower risk of this complication. Obviously, that's something that we need to do more of a deep dive in, but I thought that was interesting. Here are our CPT codes for the lumbar puncture. And then don't forget, if you use ultrasound, you actually can charge a separate charge for using ultrasound for lumbar punctures. And that's the CPT code 76942. Adds a little bit to your charges and receipts. And then finally, for central lines, you can see our pneumothorax rate is 0.4%. Our CLABSI rate was 1.3 versus 1%. And so we're looking a little bit more closely at that. And our arterial dilation rate was, again, low at 0.2%. Here's a CPT code for central lines. And then again, adding ultrasound means that you can add a CPT code on top of that gives you an upcharge. So the dollars and cents, now that we've gone through all of those things. From 2013 to 2018, these are our procedure charges. So this first year, 2013, was actually pre-procedure service. So this was the wild, wild west, which you may be familiar with, where residents were just kind of doing procedures on their own, in which case they weren't able to actually bill as far as Medicare and Medicaid were concerned, or sending a majority of our procedures down to interventional radiology or other interventional teams. 2014 is when we started our procedure service, and you can see there's the difference here of $90,000 versus almost $500,000 in charges just in that first year. And then every year after that, we've sort of been stable around $750,000 to $850,000 per year. So over the past 5 years, our charges have been over $3.5 million, which sounds really good. But then you have to think about, this is what we charge. This is not necessarily what we receive. And so then there's just a little bit more depressing graph of what our receipts actually look like. And I think this is pretty typical. So the top line, the light blue line, is the charges. The darker blue line are our receipts. And so you can kind of see the difference here. The total 5-year receipts were a little bit less than $1 million. So the big question we get asked a lot is, how do we justify ourselves? We have 2 full-time equivalents dedicated to the procedure service. And so that is clearly more than what we receive in any given year. So how do we justify this? We have a chair who is very interested in improving resident education and feels that well-rounded, well-trained residents should be able to do these procedures. And I Some of you are not at academic institutions, and that's not a justification. Or some of you may not have chairs that actually thinks that, you know, internists should be able to do procedures. So I think the biggest way that we justify ourselves are increased patient safety. So you can see that our complication rates are low, sometimes lower than published. We prevent avoidable admissions. So we do have clinics that are hospital-based clinics, in which we go to those clinics and we do parasynthesis and thoracentesis, for example, for the oncology clinics, and we can prevent admissions that way. Our team also goes down into the emergency department and helps do procedures that patients show up to get, and we're able to discharge them home and avoid an admission that way. The hospital sees that we offload interventional radiology. And so if you have interventional radiology at your institution, maybe they're really fast and it goes from, you know, consult to interventional radiology to the procedure pretty quickly. At our institution, they're busy. And so when we consult interventional radiology, the time of consult to the time of the procedure, there can be a significant delay there. And so we offload IR to procedures that we can do at the bedside. And we offload interventional pulmonology so that they can do things that need to be done in the Bronx suite. And by doing that, we decrease length of stay sort of across the board. These are all kind of difficult to prove to the C-suite. And so you'll find this in our paper. There was a study done by Barsuk et al., who looked at parasyntheses, referred to interventional radiology, and they increased length of stay by 1.86 hospital days per case. And we found that that was fairly true for our institution as well. So if you extrapolate our data, we did over 2,000 medicine procedure service performed parasyntheses. We get to them the same day. And so if you extrapolate, we avoided 3,757 hospital days over that 5-year period. And so the per ARC, every hospital day is about $2,000. And so we may have saved the system more than $7.5 million over 5 years for parasynthesis cases alone. And again, that doesn't even take into account the admissions that we can avoid by having a procedure team. So this, I'm done talking. This is the QR code for that paper in case you want to refer to our work. And then at this point, I see a lot lit up in the chat room. I'm going to stop sharing, or actually, no, let me not stop sharing in case you guys wanted to go back to certain slides, and we can kind of go through questions.
Great job, Ria. Tons of questions while you were speaking.
Okay.
So I'm going to let Gordy take over. He's going to help us.
Yeah, Gordy and Ricardo and Ria, thanks so much. I think Gordy will field the questions here. We may repeat some of the questions for the recording portion. So Gordy, feel free to summarize any, or Drs. Franco and Dancel can take over that role as well. Feel free to color in some of your responses that I see Dr. Franco had responded with. So.
Yeah, so just one of the first questions is, which kits are you using, Dr. Dancel?
Oh,
and why?
Ours are all over the place. And I don't know that can I say brand names? So our central line kits are different than the kits that our trialysis catheter kits, which are different than our parasynthesis and thoracentesis kits. They really are all over the place. And I think that just has to do with the agreements that we have with certain vendors.
Okay.
So regardless of the kits you use, the catheters used may be changed. Most of the kits come with an 8 French or a 6 French catheter. And someone asked before, in order to reduce your chances of having leaks, specifically in parasynthesis, reducing the size of the catheter to a 4 French that you drop into the field might be helpful.
Dr. Franco, have you found that old zigzag method makes any difference?
Yeah, that's very common, a common question, but you just think about all the time that you spend trying to locate a spot, then do all the scanning to look for vessels, just then to displace the entire subcutaneous tissue and puncture on a site that you haven't marked. So I would say we've done, in all the series that I have participated, we have used the Z method 0 times, 5,000 procedures, and the leak hasn't changed or increased at all. We do
Yeah, I
not
see
use
that.
it routinely.
Dr.
that was-
Salome agrees with you too. Sorry, Dr. Dancel, go ahead.
No, that's okay. That was a question from Robert. Hey, Rob. I agree with the 5 French. So I think Ricardo is correct that ours is also a larger catheter that's in our kit. If I see somebody is cachectic and they have less than a centimeter of abdominal wall, I'll typically reach for the smaller catheter. It does take me a longer time to get that fluid out. So there's obviously there's also obviously a benefit risk to think about. If they've got 12 liters of ascites in there and I'm using a 4 French catheter, I'm going to be there for a little while, but I don't want them to leak. So you just have to take that into account. And then if they have a lot of anasarca, I find it almost doesn't matter what size you use, they're going to leak. And that's just part of the, so that's just part of the consent process, and the information that I give them before I get started is with that amount of wall edema that they probably will leak, and there's not much I can do about that.
There's a great question from Dr. Dar when it comes up, interested in starting a procedure service, yet how do I get my faculty trained? Let's talk to you, Dr. Franco, first.
So faculty training is paramount to the success of your procedure service. A bad outcome will take away the reputation of your service and set you back about a year. So we did a little bit more training, more intense. We had the prospect candidate rotate as an observer for 2 weeks. Then they became the primary operator over 2 weeks. And then when their first rotation, we assigned a senior to shadow them to be able to be available for any questions, anything that made them uneasy about the procedure. And so it was about an 8-week period of supervision before they were allowed to just go free. And many of them welcomed it. So I would say make it a big deal to train your faculty properly, and also monitor the quality of their images so that you know that they are, obtaining good quality images before entering any type of cavities.
Dr. Dancel, do you have anything to add to that, or inspiring faculty to join your team?
I have to say a lot of our faculty are hired. We're inbred. People like to stay here in North Carolina. I don't know why, but a lot of them are folks that we already know, and so they have experience with the procedure service, and they know that it's a dynamic service. It's great teaching. The residents really like it. They're very excited to be on it, and it's a fun procedure. It's a fun service to be on. So we usually have no problem getting new faculty. We do. The problem is not having spots for them, because all of our old faculty want to just stay on the procedure service forever.
All right. Another quick question about LPs, Dr. Dancel. How do you choose who you use ultrasound on, and do you do it under dynamic or static guidance?
I use ultrasound on everyone, regardless of their BMI. And that's because I can, maybe even folks that I can feel in landmarks, I like to try to challenge myself. So I'll feel the landmarks and I'll commit to a spot just by feel. And then I'll use ultrasound and I'll figure out if that spot actually has the widest spinous process. And sometimes I'm wrong. So I use it on everybody, and I go with not necessarily the one that I can feel the best, but the one that has the biggest interspinous space. I use it on children. I use it on babies. Yeah, I use it on everyone. And I use static. I don't do dynamic. Ricardo, do you use dynamic?
I have to completely agree with you. Dr. Patel, Sanjay Patel, who is in this chat, he was with me when we tried to do this ultrasound guidance, and we started at Cook County Hospital. And we were initially doing it only in patients where we thought we needed it, just to discover that we were as bad with or without ultrasound. So we decided to practice our ultrasound and use it on all patients, easy and not easy patients. That is what gives you the expertise to later use it in a more challenging patient. So using it 100% of the time is just making you an expert operator, which is the most important part of doing the ultrasound later.
Another quick question, hemodialysis lines. Again, start with Dr. Dancel. Do you do temporary hemodialysis lines?
Yes, we do. It is a bloody good time. Ha, pun intended. We do dialysis lines. Here our nephrology fellows do a lot of them, but when they're overwhelmed, we'll do dialysis lines. We'll do plex catheters. I don't do PICC lines. In case anybody out there is interested in that, that is something that Ricardo has done in the past.
Dr. Franco, any comments about that?
Yeah, I would say if you are in any institution that is part of the mainstream right now, PICC lines are overtaking central lines. So, but there's just no way to do peripheral, well, yet to do peripheral hemodialysis. So that's actually replacing most central lines. Jugular punctures are mostly now for temporary hemodialysis catheters. So absolutely.
Dr. Franco, you talked about training your faculty. Do you have a way of recredentialing people in procedures? A lot of us have these procedures as residents, and then in practice, we don't get the required number and we lose our privileges. And I have people come back saying, how can I get my privileges back?
So a hospitalist or internal medicine led procedure service can also help the institution by taking over the recredentialing of people who have requested privileges but do not have the required volume. So you might help your institution and add to your value by instituting a method by which you evaluate, retrain, and recredential providers for procedures. It is just another way to exist and to be noticed in the C-suite, as you guys would call it.
Dr. Dancel, anything further?
Nope.
Okay. Dr. Dancel, you mentioned that you refer to IR sometimes. Do you ever get into the so-called turf battles there? Do they feel like you're taking away their business or any trouble there?
That's a great question. And I realize that I am very, very lucky and happy to be at an institution where the turf battles are few. And I think that may be because I don't have the ask for forgiveness rather than permission mentality. I very much in the beginning, before we even set up the procedure service, approached interventional radiology proactively. And I said, we want to have this service. These are the things that we think that we can do safely at the bedside. And also think that it's sort of a waste of your skill set in interventional radiology to be doing them down there. So we would like to take these things off of your plate so that you can do the more complicated procedures. And I think because of that approach, it worked out much better. Same sort of thing with interventional radiology. They're busy doing percutaneous biopsies and EBUSs, and a straightforward simple thoracentesis is certainly something that we can handle, and we want to make sure our residents know how to do well. So turf battles are few and far between here. I think those conversations up front are important.
Yeah,
I agree completely. Yeah,
that's really, it's hard sometimes, but to have that face-to-face conversation as colleagues is sometimes the harder thing to do up front, but definitely in the long run benefit.
And there's another benefit to this conversation, if I may add, just the fact that you sit down with your consultants with interventional radiology just helps you come to them for help when you need them. Thinking that you are not going to need to be rescued from a complication is foolish, and preparing for when a storm hits is very important in setting up a procedure service. So I in both occasions where I have kind of led a procedure service, the very first people I look to visit are the people who I am going to need to rescue me when I have a complication. Because the first thing they'll ask is, why is an internist doing this procedure? So they need to know who we are, what do we do, what standards do we use, and they are more than happy to rescue you. And I agree with what both of you said. Interventional radiology will welcome you. They do not want to, they did not do 7 years of radiology just for them to do parasynthesis. That was the answer from the vascular team that I met with in MCW.
Right.
Yeah, I found when we first trained, there wasn't interventional radiology. And I think we all got busy as hospitalists and started putting the procedures. That was the one thing you could take off your plate. And I think in retrospect, it was a mistake because we kind of lost those skills and now we're trying to get them back. Another quick question for Dr. Dancel. There's a big difference between your charges and receipts. Can you explain that a little bit?
I honestly don't think that that is unique to UNC. I think that's, so we've talked a little bit with our friends at Cornell, and our receipts are actually higher than what they've seen in their receipts. But having that kind of a gap between what you bill and what you get back is, I think, a sad reality. I'd be curious to know if somebody's getting much better receipts from what they bill and what they're doing.
I mean, the bill is standard. It all depends on your payer mix. So
Right,
there's
right.
no way for you to change that. That is just a reality of medicine.
Right. And we are the hospital for all of North Carolina. So we don't say no to anyone, whether they pay or not. And that may be a big reason why there's the gap here.
More than likely.
Yeah, there's another question about just how often your residents rotate. I think you're on a 2-week stint for them. Do they do that once a year, Dr. Dancel, or how do they do that?
They do. They do it once a year. They can elect to do it more often, and some of them actually do. The ones that are interested in going into critical care or cardiology actually elect to do more than one stint a year, but they do 2-week blocks at a time.
And how do you store your images? What system do you use, Dr. Dancel?
Our ultrasounds are set up so that they push images into our PACS system, which is then connected to our EMR. And so when we're doing our documentation, we just sort of pull up our images through our EMR, and then I'll just take a representative image and copy and paste that into my documentation so that we can bill for the ultrasound appropriately. There's a lot of ways to do it. If you don't have that kind of a slick program, people have literally done cut and paste with scissors and glue into paper charts, old school cut and paste. There's, if you have Epic, for example, you can take a picture with your iPhone and put that into your documentation. But I would say, at least at our institution, having an actual image in our documentation is important for our billers.
Just to expand on what Ria said very fast, if your ultrasound system connects to PACS, you can actually create a small point of care ultrasound division within your radiology department, and you can report on that same PACS image, and that helps with the collections for the hospital, because then they can do facility charges, and that is another argument for you to, exist in your institution.
Do you know if when you created that small service, Dr. Franco, did they add a cost? Did PACS add a cost, or was that a barrier with the administration?
When I talked about this, it's at the Medical College of Wisconsin. The radiology department created a small section within the radiology that they labeled as point of care ultrasound section. And they had an administrator who reconciled all of these images and made sure that we kind of reported them. And when I figured out why they were doing this, because they were actually having very good facilities charges collections out of our procedure service.
Ricardo, can you talk a little bit more about the facility chart? Someone had asked a question, Dr. Sagan. I hope I'm not
Yep. So Ankur, he is he was in the Medical College of Wisconsin with me, and there are no differences between what you as a provider bill or collect from a ultrasound guided procedure service and what interventional radiology does. What does vary greatly is the facilities charge, and the radiology suite time and facilities charge for interventional radiology perform procedures is much higher than if you do them at the bedside. If you do them at the bedside, there's only a facility charge for the ultrasound used, which is still a charge.
So Dr. Dancel, it looks like the timing of consults, I think that's one of the concerns, that you're going to get these consults at 3 p.m. Have you educated some of your colleagues to try to consult you guys as early as possible so that doesn't happen?
We do. The majority of our consults happen during rounds, and I think everyone's pretty good about, as they're making the decisions while they're rounding, to give us a call. Every once in a while, we will get an afternoon consult, and usually that's for patients who are who sort of need an immediate, urgent procedure, and so I don't get too grumpy about it. You know, those are the central lines that in the crashing patients that need to happen, or someone comes in with a high suspicion of SVP and they need to get a parasynthesis really quickly. But the majority of our consults happen in the morning.
Let's see. And then you also talked about doing a follow-up consult. Do you actually bill for that as a visit?
Yeah, yes, we do. We bill if the attending of record on the team that we do the procedure for is not in our same division. We can bill for a consult fee for that. Ricardo, did you guys do follow-up consults also?
Absolutely, yeah. You can set it up as a procedure service alone, or you can set it up as a procedure service and a consult service. And of course, you can improve your billing and your collections by doing so. And what you just said is essential. You can only bill for a consult when it's from a separate division, which speaks very strongly in favor of having your own division of hospital medicine. And some places are even trying to establish a section of procedure medicine. And that helps you kind of improve your returns. Yep, but we used to do it. We would do a consult, and that helps you with all of those procedures where you get called to the bedside and you end up not performing a procedure, which is actually excellent, right? You're improving safety, you're avoiding unnecessary procedures, you're doing such good, yet you walk away with nothing and a complete perception of non-existence. But if you are able to put a consult, then you are actually relevant.
And I'll jump in next here, helping Gordy out with 25 questions at the same time he's receiving. So there's one here. How do you develop a hospital's core and procedure training? My group has only me that's interested and maybe even comfortable doing procedures. How do you build competency? How is that through simulation? Is there a set amount of observations? Value your tips. So
Ria?
either Dr. Franco or Dancel. Yeah, go ahead.
I feel like Ricardo may have a better answer for this one, because a lot of our newest proceduralists are ingrown, and so
Yeah,
we know there's
yeah, you're privileged. You have they come trained to you already.
I me.
But to answer that, absolutely, one at a time is the answer. Do not aim for more than that. You find one person who has the commitment. And what we did is we set up a screening. And I think Sanjay and both Ankur can attest to this. We would tell you, if you want to be part of a procedure service, you need to commit to come on your off-service time for 4 weeks. And if you do that, then we saw that there was commitment for training. And then we would dedicate 4 weeks to train you, which would give you the basic competency. In 4 weeks, in a busy procedure service like Ria's, you will do about 20 to 30 procedures. So that'll help you, gather some confidence. And then we give you proctorship. One at a time is the right answer.
Dr. Franco, is there any sort of publications or write-ups on how to go about that protocol or process? Is there a way to, like SHM's diagnostic ultrasound, there's a set amount of images to complete. Is there something like that that's a rubric, or is there a lot more art to this than meets the eye?
Well, I'd say both, right? There is a rubric that as part of the Journal of Hospital Medicine publications. And there's also this art of being able to be with someone and getting commitment from them and then offering them one-to-one mentoring.
Wonderful, thanks. I see that Dr. Sagan put in training is 6 weeks at Medical College of Wisconsin. That's fantastic. So, and how do you keep, again, a follow-up question to that that's coming in, how do you keep that procedural competency going? If say someone took 6 months off or a year off from service lines for various reasons. Life is busy. There's pandemic going on. Things can happen, right? How do you rebuild that competency or confidence? Or is there some sort of quality assurance process that you're developing in this with your group?
So I just wanted to go back to the prior question about training de novo, because Linda Curry and Dr. Curry had a really good point about if there really is no one else that can train, maybe you could go to interventional radiology or interventional pulmonology or EM and say, can I do some procedures with you to get my skills up? We keep, as far as ongoing training, we keep our procedure service very tight for a reason. There are 10 or less of us at a time, and many of us have been proceduralists since 2014. So it's almost individual based. If I have a proceduralist and I know how they are with their hands, and they take 6 months off or a year off, I think them coming back is less of an issue than someone that didn't have years and years and years of experience and then have time off. So I guess the short answer is it's sort of a case by case basis. Everybody has their learning curve and their training curve. I like to do a lot of simulation training before touching actual patients.
Thanks so much, Dr. Dancel. I'll hand it off next to Gordy for a couple more.
Yeah, another follow-up to that, Dr. Dancel, just teaching your residents, do you have a bank of videos or something you can send them to review before they start on your service? Or do you just kind of train them in real time?
I have a bank of trainers. I really do think that this is something that they just have to have their hands on the probe and on a needle, and they get their hand-eye coordination. I tell them to play a lot of video games, almost, jokingly, but it's really just watching them and watching how they move their hands in conjunction with the ultrasound and having them practice that over and over again. So I have a parasynthesis trainer, a thoracentesis trainer. We have vascular trainers. And so I'll do that with the residents before we get into a room with the patient, just so I'm comfortable with the skill set that they have.
I see.
Yep,
If people want to post something about what they're using as far as simulators, I know Dr. Salome has developed some as well. Feel free to put it in the chat for people to look at. If you have ones that, I know there's a lot of them out there, they tend to be very expensive.
They are expensive.
Yeah. Go ahead, Dr. Ricardo or Franco.
So I was just going to say, to expand on what Ria said, just a set of basic training to be done, and then a lot of supervision. The simulation is very important. We used to start with central man, big juicy jugular veins. Everybody gets them like after 3 tries, but then we would give them an afternoon or at least a couple of hours with a small blue phantom with smaller peripheral vessels, and would ask them to go again and again until they were proficient at guiding their needle. And that led to such better outcomes at the bedside. So specifically for central or peripheral access or central access, that's where I would kind of do more time spent with the residents.
And it doesn't have to be the expense. I think it's a really good point, Ricardo. Some of these trainers are thousands of dollars, but it doesn't have to be. And honestly, Gordy is sort of the expert at sort of making trainers with tofu and all sorts of things that you can get very, very cheap. But honestly, if I take a dime and I put that in a block of tofu and I tell the residents to use the ultrasound and hit it every single time, that's a much smaller target than a big fat juicy IJ.
Yeah, I am in full agreement with that. Do you, Gordy or Benji, do you have any other questions? Because there's some questions by Jerry Salame.
Yeah,
there.
feel free, Dr. Franco, just pick them up and respond to them.
Jerry's talking a lot about how we consider to add a point of care ultrasound rotation. And I think so. By the time that you hit about 8 to 10 procedures a day, you have enough game or skin in the game to request a second ultrasound and then use one of your 2 rotating residents to do diagnostics and have the other one do procedures and then alternate. And that just does a lot of good and the reputation of your team. Also, how did you get time? Was your time covered? It wasn't. You have to be kind of, that's why I say you have to request true buy-in from the person who's requesting you to train them. So we use half of their time on their off time rotating and half of my time in my off time in order to supervise them, or at least to guide them through procedures. So you won't have them all pay for it. But what Ria said is absolutely true. If you build it, it will done. It will. They will come as long as you make it responsive, so that it's all procedures are done the same day, and that you communicate with your consultants. Things will happen.
Another quick question, then we're just down to the finish line here pretty quick. Consults, do you ever consult on the same day you're doing the procedure? And if so, or why not? Can you bill for that?
That's what our interventional pulmonology team does. And so I think that it is possible to do an initial consult to do the procedure and then do a follow-up consult and bill for all of those. Having said that, we do the procedure one day and then we do a follow-up consult within 48 hours after. But I think that it is actually possible to do the initial consult, procedure, follow-up consult, and bill for all of them.
Yes, it is. You have to choose what suits you the best. We drew some lines, and those lines were not crossed, and it's up to you and your institution to draw your lines and keep them.
Yeah, thanks so much. We are coming up the close here. I have one more question, and maybe if final words from Dr. Franco and Dancel to close here, unless Dr. Johnson has anything more. But I say, looking forward, what opportunities are there in research? What research questions remain in hospital medicine POCUS and procedures? We've done a lot of descriptive analysis. There's program descriptions. Is there anything more that you think that could be helpful to look at, that the groups could partner with? Love to hear your thoughts, or maybe the group's thoughts here.
Ria?
There's so many. There are so many. I think one of the big ones that we've talked about is real-time ultrasound guidance versus dynamic ultrasound guidance for, real-time ultrasound guidance versus static ultrasound guidance for lumbar punctures is a big one. I think that you can think of a few projects offhand that we could partner with.
I mean, that's why we do these webinars. I would say to come is, can we use pooled data from hospitals-led procedure services to demonstrate that we are as safe and as good as all other service lines? The next one would be, I mean, I agree with you in the static and the dynamic, but I mean, have we even been able to use our proof data to demonstrate that we have a higher success rate, satisfaction rate, less complication rate from static guided, ultrasound guided lumbar punctures? Have we standardized how we train? Have we standardized how we evaluate? There's so much that we could answer. Those are questions that I think are low-hanging fruit to be answered.
I agree. If you start your own procedures, I will say that the reason why our manuscript, some of the feedback that we got from our manuscript is, why didn't you look at the complication rates before you started your procedure service and then compare them to afterwards? And the reason being is it was such a wild west before we even started our procedure service. The residents were just doing see one, do one, teach one, just doing them alone. And it was hard to even pull that data. So if you're thinking about starting your procedure service, it may be worthwhile to just get baseline data. And I think you could probably make several publications after you start your procedure service.
Perfect. That's great. And so as we wrap up here, final words from the two of you. If you had an audience here with 38, 40 people here, and then much more listening online and recorded, I think, what would you tell them in terms of advice for as they start to navigate building a procedure service? Anything else? Dr. Dancel, if you want to start, if there's someone novice that's coming to you, hey, I want to start this, how would you coach them and encourage them?
You know, it depends on who you're talking to. It's an easy sell if you're talking to residents and residency programs, because I think that trainees want to learn how to do this. If you are not academic and you are talking to your C-suite, obviously that your path to success is going to be a little bit different, and you're going to have to sort of train them to think in terms of non-dollars and cents ways that you can help your system. Or at least not ways that are concrete things that they can count. So how can you change the length of stay? How can you make sure that everyone is, you know, VIR and interventional pulmonology are doing are working at the top of their training. How can you make sure that everybody moves through the hospital faster and avoid delays? Those are the sort of arguments that I would make to a C-suite. And then just sort of start small. It really helped to start small the way that we did in that model of we just needed one procedure a day to pay for one ultrasound machine. And after that, we sort of proved our worth to the system in general. And then they sort of bought in and supported us more and more.
Thanks so much, Dr. Dancel. Any final words there, Dr. Franco?
Yeah, I would say some words of the wise would be involve all the power players, which would include people who will help you and people who you foresee are going to be stumbles. Do not start running before you start walking. So stop first, look at your baseline data, plan it very well, establish a good way to record over your procedures and all the data that you think that you are going to be collecting retrospectively so that you can prospectively collect it in order to publish. You can also make sure that your training is standardized to all of your operators. Standardize how you are going to set limits on safety for procedures. Make sure that you publish within your institution your guidelines for INR, platelet count, indications and contraindications for your own procedures so that your procedure service is acting in a standardized way. And it's not like if Franco does it, he does it this way. If Dancel does it, she does it this way. And that will give you more reputation. And that will help you be safe and to publish later on.
Well, a big thank you. Thanks to Drs. Dancel and Franco. Thanks to my co-host, Dr. Johnson, and to the SHM staff for supporting and all of you for joining. Stay tuned for further opportunities via SHM. Thank you all. Kevin, any other final words?
No, just thank you for everyone for attending. Thank you, Gordy, Benji, Ricardo, and Ria for your time. We will get this up in HMX and looking forward to our next webinar in July. Thank you so much, everyone.
Bye, everyone.
Bye-bye, everybody. Have a good day.